Are you going to be able to advance the slides?
Yes, I am.
Excellent. Okay. So my name is Julianne Francis. I'm a gynecologic oncologist. I worked for many years at Queen's University, where I'm still affiliated, and left a few years ago to open a new gyne-oncology program in Durham region. I do spend a lot of time in the north in Moose Factory. For those of you who know where that is, it's sort of at the tip of James Bay, and it services a wide region around James Bay. So I've really enjoyed my past 12 years of working with the Aboriginal community. So that's kind of my credentialing. So we can move forward to disclosures. And really, there's just one disclosure, which is I do have a vagina, but beyond that, I don't work for any drug companies or anything like that. We're going to go ahead to the objectives. And I'll acknowledge that, and please interrupt me at any time if you have questions. I don't know if I'll be able to see if you're asking questions, but somebody stop me or just shout out. In looking into how to present this, I actually found that it was very complicated because vaginal pain is such a complex issue and there's so many causes of it. It's difficult to speak about it briefly. So what I've tried to do here is to just provide you with an approach and a way to think about it. But by all means, if you have more questions, don't be afraid to phone a friend, because it's in fact a very complex area. So what we're going to talk about is trying to identify which one of the pain syndromes we think that we're dealing with when somebody says they have vaginal pain, reviewing some of the more common ones, and some of the options that are available in terms of management. So next slide. So when it comes to vaginal pain, the first thing you have to do each time is take a history and do an examination. And I don't mean to be trite when I say this. I mean a really thorough history with specifics to the vagina and a really particular examination. But being able to understand and distinguish between different types of vaginal and vulvar pain that people are having is really key to being able to understand why your patient may be having the pain that they're presenting with. So next slide. So the International Pelvic Pain Society has an excellent pelvic pain assessment form that I would encourage you all to take a look at and use. I didn't add it here simply because it's 11 pages long, so there wouldn't be time to go through the whole thing, but it does take a look at all aspects of the patient's history and a very thorough patient examination. And you may feel that you don't have time to go through all of that with the patient in clinic, but fortunately, most of this document is actually self-reported by the patient. So you might want to consider even getting the document filled out ahead of time, and then that will give you an opportunity to review it and to see what types of questions and concerns the patient has and what they're experiencing specifically, because all elements of their pelvis is really important in terms of being able to determine what's needed here. And I will provide a link for that after the talk. Next slide. So a little bit about the pathogenesis. Why do people have pelvic pain? And this is where it starts getting really complex. So I'm not going to go heavily into a lot of these areas. Instead, I'm going to focus more on an approach you can use. But the problem with vaginal pain is that it's not got one cause. So the cause could be inflammation. That could be generalized inflammation. It could be inflammation for a wide variety of reasons. It could be neurologic proliferation and sensitization. So in some patients, they just have an increased density of intraepithelial nerve fibers, and the pain and discomfort that they can get can persist long after the initial cause of them developing that proliferation, like infection or trauma, has resolved. So that can be ongoing and it can be very difficult to manage. The patients can have infections. It could be genetic. Some of the polymorphisms in the immune system respond differently to trauma or infection. And in women who have chronic pain, you get a stronger inflammatory response. And some of this can be genetic. And we even know that looking at different ethnicities, people have pain that is different, like they have different amounts of pain related to the same amount of stimuli. And they have actually checked this looking at patients like at minority communities living in a broader community, or if you take like what was the majority and put them to be a minority in different areas, we still see the same thing. There's some ethnicities that feel pain more. Allergies can cause it. You can get a strong histamine response. It can be hormonal. It can be myofascial pain, or it could be psychological. And so because of all of these different causes, it gets really complicated how you're going to look at it. So next slide. I'd like to give you an approach that will be like a little bit more straightforward to think about when you're seeing your patients. And that is like, what kind of pain is the patient having is question number one. So you'll find that if you question your patients thoroughly, they can describe the pain that they're having really specifically. They will say that it's burning, or it's stabbing, or it's throbbing, or it feels raw, or it feels like there's a bunch of little knives down there, or they're having pain during intercourse. So question number one is, what kind of pain is the patient having? Next slide. And the next question is, where is that pain? Like, where specifically is the pain? Is it like exterior, just at the introitus? Like, is it like in their vagina generally? Is it deep pain at the top of the vagina? Is it sort of superficial and interior that they're feeling it? So where are they feeling that pain specifically is your next question. Next. So I felt like a way to talk about some of the causes of this would be to just think about what is the pain that the patient is having. So the first pain is, the pain is with intercourse. I have intercourse, it is painful. So next slide. So this is historically called dyspareunia, but as you know, in medicine, we often like to rename things. So I believe it has been renamed female sexual pain, but we're all talking about the same thing. And this is vulvovaginal or pelvic pain that is provoked or exacerbated during sexual contact specifically. So if they're not having intercourse, the pain is not there. It can be mild to severe. It can be in a very specific location, or it can be generalized pain. They may have had this pain all their lives, or there might have been like an acute event that caused them to start having pain. And in some cases, it can be idiopathic, or it could be secondary. Next slide. So risk factors for this include things like PID, depression, anxiety, history of sexual abuse, Black race, perimenopausal status, and age less than 50. So there was some discussion because a lot of these were from aggregate reviews of what is going on. And there's a question of like, how can it be that a risk factor is being young and a risk factor is being in menopause, and how do those two things work together? The issue is that it may not surprise you to learn that typically younger people are having more intercourse. I'm not judging anyone. And so like the reported dyspareunia is less in older patients, but because of hormonal issues, intercourse can get very painful when people are older, but many patients will just abandon it. So this is something that can span the entire age group of patients. Next slide. And I just want to take a moment here to talk a little about the Aboriginal community and First Nation communities and pelvic pain specifically, and to talk about how certain things apply and don't apply. So I think it's really important to understand victimization rates, and I'm sure this is like not a surprise to anyone that is on this call. But I just want to take a moment to like look at some of these actual numbers that we see. So when you take non-First Nation people, and this is in Canada, the risk of being assaulted by a former partner is 7%. But if we look at First Nation communities, that risk is 24%. there's an increased risk of abusive relationships if the relationship is common law versus married. And so in non-First Nation communities, that increased risk is 13%, but in First Nation communities, it's 217%. And then similarly, in terms of rates of sexual assault, we see that the number is almost 10 times as much, with the numbers being much higher in communities that are in the far north specifically. And there's a lot of information about this that the Government of Canada collects. And they actually, I was surprised, seem to draw a lot of insight into the next slide. The legacy of residential schools and that translating into things that are happening in the community right now, because they've looked at the inability of people to have as much trust in their relationships, and were able to draw a series of lines that connected that to like pelvic health that women have today. Next slide. So when we look at identifiable causes of dyspareunia, some of the causes we see are hormone related. So whether it's estrogenized or non-estrogenized, it could be infectious, which is the candidiasis, the STIs, and the PIDs. And it can be anatomic. So myofascial pelvic pain syndrome, Mullerian abnormalities, and prolapse. So I won't have time to get into all of these, but I will talk about a few of them. Next slide. So in terms of localizing the pain, if the pain is right at the introitus, you're going to say that that is most likely vestibulodynia or vulvodynia. So that's pain that you're having right at the introitus. And then pain that people are having, like that's generalized, it's everywhere, is vaginismus. And then pain that patients have that is like very deep is most often associated with endometriosis. And endometriosis is a whole separate talk for a day on its own. I'm sure you're all well aware of it. I'd be happy to come back and talk to you about endometriosis. So I'm not going to have time to delve into endometriosis today, but just so you understand that the deep pain is more likely to be associated with endometriosis. So if we go to take a look at vaginismus and vestibulodynia or vulvodynia, the vaginismus may be related to what kind of history that patient has personally. But there's been quite a lot of literature to say that the vestibulodynia, so the pain that's right at the introitus, is very specific and doesn't tend to have as much of a psychosocial component. So when patients have vestibulodynia, it's not the same thing as if they have vaginismus. There's not really a psychological component to that. Next slide. So when we say that the pain is throbbing and stabbing, next slide, that is when we think that it's probably more of a myofascial pain syndrome. So this is when you get short, tight muscles in the pelvic floor. And in this case, you sometimes may have palpable nodules or trigger points that you can palpate. The cause of this is unknown. There are a bunch of theories on it. One is that it's acute overload, that there's like muscle trauma, that there's been repetitive overuse, that maybe psychological stress or some type of visceral disorder can cause it. But like there's a lot of theories, but no one really knows what the true cause of it is. The way that this is managed best is with physical therapy in some instances, pharmacotherapy in some instances, and psychological counseling in some instances. Next slide. Which is why it's really important to like go back to the basics again and get a really, was that a question? What would be an example of acute overload? So an example of acute overload, can we go back one slide? Would be somebody had an event happen recently. They may have had surgery in their recent history. They might have delivered a baby in their recent history, and this type of thing. Repetitive overuse, like we may see some of these instances occurring in women who are involved in the sex trade, and muscle trauma is like muscle trauma. Next slide. And next slide. So when you're involved in this, you're going to want to do a very specific patient evaluation, where you're looking at MSK, so not just the muscles themselves, but also the joints and how the patient is moving, at their pelvic floor muscles, and also at the soft tissues around it. So the patient's posture and how they're walking is very important, and how they're even standing. There's a particular posture, which I will show you a slide of in a minute, that is kind of associated with pelvic pain. Unfortunately, this particular posture has its advantages, so it tends to be associated with lower levels of back pain, but it is often associated with patients having pelvic pain. On physical examination, you want to really careful and explore really gently, first on the outside, and then palpating the pelvic floor muscles, and doing a very specific exam. The exam is usually kind of in 3 phases. So you want to have both an active phase and a resting phase of your physical examination, so that if you're just doing nothing and you just gently have your finger there, are they having pain? If they're trying to squeeze your finger, does that cause pain? If you put pressure there, does that cause pain? So in each of the muscle groups that you want to be assessing through the pelvis, and in each of the areas where you're assessing, you want to sort of get an active phase and a restive phase in terms of the examination that you're having, and how much discomfort is the patient having with all of that. You also want to assess what their range of motion is, and do an examination of their abdomen and their pelvic musculature. And what is very helpful is pain mapping diagrams. So it's helpful to get some pictures and allow the patient to point to where they're feeling the pain specifically. Next slide. So I drew some pictures here just to give you a sense of, and I used this one picture, which is was the only one I could find that showed this exact diagram, but you can see the hand there doing the pelvic, but it gives you a sense of when that finger is there, you're pressing on the rectum, you're pressing on the levator ani, you're pressing anteriorly on the base of the bladder and around the urethra, so that you can feel each of these muscle groups specifically and try to understand where exactly the patient is experiencing that discomfort. Next slide. And so this is the pelvic pain posture where you have a J spine. So if you can get the patients to sort of tilt, this is part of physiotherapy, sort of tilt their pelvis in, then you'll find that they may not have as much discomfort. However, like the pelvic pain itself causes people to have this severe lordosis and anterior pelvic tilt. Next slide. So patients who are more symptomatic may have more treatments. Specific to some of the communities that I work with are not near large medical centers. So it's useful to know that if patients are coming from far away, they can do daily treatments of 2 hours a day for a week at a time with physiotherapy. So if they're coming from a long way away and you want to sort of improve what's happening with them over a short period of time, you can actually do very intensive pelvic floor physiotherapy over several days to weeks. The type of thing that's not helpful during this rehabilitation phase is Kegels, vaginal coitus, prolonged sitting, or tight underwear of any type. So what gets done during the rehabilitation phase is some myofascial manipulation. There can be some neural mobilization. So they'll be like doing some dry needling and sometimes injections. There's active and passive stretching with some connective tissue manipulation, some scar tissue manipulation, manual therapy, and pelvic floor re-education. So there's a lot involved in pelvic floor physiotherapy, and there's quite a growing number of physiotherapists that are looking towards that specifically. Next slide. Okay, so let's say that the pain is burning and soreness. Next. So that's when we're talking about the genitourinary syndrome of menopause. So this is what, when I was training, we used to say was vulvar or vaginal atrophy, but it's been decided that, I guess that maybe that's a little pejorative. So since 2014, the new term is genitourinary syndrome of menopause. And what women experience with this is that they get vulvovaginal dryness, they get decreased lubrication during sexual activity. There can be dyspareunia, including vulvar or vaginal pain. You can have bleeding, decreased arousal, orgasm or sexual desire, burning, irritation, itching, some types of abnormal discharge, which I will talk about discharges next time. And many patients will have urinary tract symptoms related to this. Next slide. So when it comes to this, again, we're going to go back to the basics. And so this is typically age related, but you don't want to be too fixated on the patient's age only, because we see this a lot in patients that are postpartum, particularly if they're breastfeeding. They can have pretty significant symptoms from this. And in some cases, it's idiopathic. So many patients will be young and have a hysterectomy or have their ovaries removed or other oncologic type treatments. And those treatments can cause patients to have these syndromes at very young ages. Next slide. So when you're examining the patient, there's a series of things that you may see. So you may see fusion or resorption of the labia minora. So instead of seeing like a nice labia minora and then sitting on the labia majora, it's like all one thing. The tissue can be very fragile. You may see petechiae, or it gets fissuring easily. You may see that the introitus is retracted, so it becomes very tiny and small. The urethral meatus becomes very large, so it looks like there's a large prolapsing urethra there. You may get pallor, so it's looking very white, or erythema. And then you often have loss of the vaginal rugae, and you have decreased secretions and decreased elasticity. So there's just some pictures there to show you what all of that looks like. Next slide. So I'm just showing you kind of a contrast between like a healthy, younger vagina and an older one, and what we often sometimes see. So when the vagina in a younger woman is got these healthy vaginal rugae, it's really thick with glycogen, and that is important because the glycogen is a substrate for the lactobacilli that live within the vagina, and the lactobacilli convert glucose into an acidic acid. So basically it keeps a nice acidic pH of your vagina. So the natural pH of the vagina would be somewhere between 3.5 and 5. And at that nice healthy pH, you get like thriving, proper vaginal flora there. When the pH starts to rise because there's less glycogen, therefore the lactobacilli can't convert as much glucose, and there's not as much acid there, then what you have is overgrowth of bacteria that you don't want in the vagina, and people can get lots of vaginitis, cervicitis, and all these types of things. So one of the things you might see as the vagina starts to lose that estrogen and collagen is that you've got loss of rugae, and you get this very thinned out, very white, very fragile looking vagina. Next slide. So when examining these patients, I think it's always like appropriate to make sure that you have a nice range of sizes of speculum. So with the speculi, like I always make sure that I use one that's appropriate to the size of the vagina of the patient that I'm examining. So typically on any of my older patients, unless they're grand multips, especially as they get into their 70s and 80s, I will always consider using a Peterson speculum over a Graves speculum. And you can get a Peterson in a medium or a large or a small, but so you can still get length with it. But a lot of times as the vagina starts to atrophy, you get a narrowing of the vagina. So opening the graves can be quite painful. Next slide. So how do we manage this? So you can use vaginal moisturizers, or you can use lubricants, or you can use hormones. The difference between a moisturizer and a lubricant is really that a lubricant is used at the time of intercourse, and a moisturizer has more of a longitudinal effect. So the common lubricants that people would know would be KY, but you know, there's Astroglide and there's a wide range of them. And in fact, KY tends to be a little bit stingy for a lot of patients. So I prefer Astroglide if I was going to recommend anything myself. But as I said, I don't subscribe to any particular drug company. The longer range moisturizers would include Replens, Repagyne, and there's a wide variety of them. And most of these can be bought over the counter at any drugstore. But at the end of the day, there's nothing quite like the hormones. So Premarin or Vagifem can work really nicely for patients. And these solve a lot of their not only vaginal pain, but quite often they'll have an improvement in their bladder discomfort as well. Next slide. So let's say the pain is stinging and rawness. So then what we're thinking of is, next slide, vulvodynia and vestibulodynia, and these tend to be very associated with vaginitis. So vulvodynia and vestibulodynia are basically vulvar or vaginal pain of no known cause, although there is a subcategorization of them that come from a known cause. So the ones that come from known causes will be the multitude of vulvar dystrophies that you're probably aware of, like lichen sclerosis, lichen planus, and other types of vulvar dermatoses. But the ones that we really struggle with are the ones where we don't really have a diagnosis for this. So we kind of name them based on location. So if it's a clitoris, we would say that's clitoridynia. And if it's in the vestibule, we say that's vestibulodynia. And if it's on the vulva, we say it's vulvodynia. And so it can be provoked, spontaneous, or mixed, by which I mean like something happened, like they had intercourse and it's painful, or it's painful all the time, or some combination of the above. And the onset can be primary or secondary. And the temporal pattern can be intermittent, persistent, constant, or immediate. The prevalence of this is actually quite high. We think it's around 12%. Part of the problem is that patients don't tend to report it so consistently. It depends on the patient population that you're talking about, whether or not it would be reported. And also there's like some variability in whether or not you would actually seek medical attention for it, even if you were aware of it and would report it. So we do see some variability with that. So the exact number is not completely known, but we believe that the prevalence is about 12%. Next slide. So again, to go back to the basics, next slide. In terms of diagnostic criteria, we want to say that it's pain that's located in the vulva or the vestibule with or without the clitoris. There's no identifiable cause. It's lasted at least 3 months, and you can elicit this pain with pressure point testing. So you can just touch the patient and you can elicit this pain. Next slide. So when we do an examination, we usually start externally, and we'll use a Q-tip. There's a subset of patients who with even like the slightest touch with a Q-tip will have pain. We call that allodynia. But otherwise, like you would touch around with the Q-tip and see if they have the pain. They can often locate the pain very precisely. And when you're going to do the examination, like these patients are often very uncomfortable. So you want to start with a single digit and just go really slowly and use a small speculum. And then if the patient is able to tolerate all of that, then you can consider admitting a second finger and doing more of a pelvic examination to feel other structures within the pelvis. In particular, if you do a workup on these patients, the labs will come back negative and the imaging will come back negative. So it's really a clinical diagnosis. You don't need a lot of other investigations. Next slide. So some of the risk factors for it are anxiety, depression, and childhood sexual and physical abuse. But as I had mentioned at the beginning of the talk, there's a lot of thought now that specifically vulvodynia can be very precise, and we're not as clear that some of these psychosocial factors play as much of a role in it, and it's getting a little bit more credibility that this is its own diagnosis that may not have as much of a psychosocial component. Next slide. So one of the things we see with this a lot is like candidiasis and vaginitis. So one of the things you can see is that there is a surface receptor that can bind Candida albicans, which is the regular Candida that we see, and it causes this huge inflammatory chemical response. So many of these patients that have vulval and vaginal pain have a strong history of recurrent yeast infections, and that rate is 70%. So when you see patients that have recurrent yeast infections, they're at high risk of developing this pain syndrome. Next slide. In terms of management, so there is control of recurrent or acute infections. So it's very important to take care of these infections as soon as possible and as completely as possible. But some of the inflammatory response that patients develop can become permanent. So in the case of vestibulodynia specifically, there is a surgical procedure where you can just resect the vestibule and then reconstruct it. And many patients have excellent relief from that. However, it's obviously significant as a surgical intervention. So it's not usually our front line of management. Next slide. So in summary, this is a very complex subject, but the type of management that you would give to the patient is really based on the diagnosis that you've made. And you are going to make that diagnosis through your very thorough history and physical, and I will share the document with you. And like, please don't be afraid to phone a friend because it is complicated and it does take some time to become more comfortable with it. It's great. And that's it.
All right, thank you very much. Are there any questions for Dr. Francis?
I can talk a little bit about prolapse. So prolapse is one of the subjects that I felt like is a subject in and of itself. But as many of you are aware, like prolapse is it's a common event. Like there's a whole subspecialty of gynecology that is basically just dedicated to prolapse. There are multiple surgical repairs that we can do with respect to prolapse, and the type and the nature of the repair that a patient would get is dependent on the type of prolapse that they have. So is the bladder falling down? Is the apex of the vagina, so the top of the vagina falling down? Are they getting a defect posteriorly? So these are cystoceles, enteroceles, and rectoceles. And then sometimes patients will have a combination of all of the above. You can have some improvement with Kegel exercises, but in the North American population, we haven't been as successful with Kegels as they have been in the European population, but we still recommend that patients do them. And so one of the management strategies that we have is like a pessary if you are not able to do a surgery. So in my time working in Moose Factory, we lobbied quite hard for there to be training of nurses and especially nurse practitioners in some of the more remote communities on fitting a pessary, because that's something that is managed by nurse practitioners nationally. They often work jointly with a urogynecologist or a gynecologist, but nurse-led pessary clinics are a thing, and I think that would be a huge benefit to the community. Someone flashed up a question there, but now I can't see it. Can you repeat that question?
Sure. It's they're looking as a nurse in isolated areas. How can we
Yeah.
do a proper assessment and describe findings?
Yeah, so I think that's why I was recommending the document that I was discussing, because it goes through step by step everything that you would need to check, right? So like the document sort of leads you through all of the assessments that you need to do. And I think it's a pretty invaluable resource. So it will allow you to be able to describe the findings that you're having in a way that will be clear to a specialist if that's where your patient is being referred, so that they can either just give you direct feedback on what they think would be helpful, or express that the patient would need to be seen directly.
Are there other questions? So while I give you a second to think about that, Dr. Francis, you're coming back again to do another presentation. Is that correct? And what is the topic of that presentation?
Well, the topic that was requested was vaginal discharge. But if you wanted to learn something about prolapse specifically, or if you wanted to know more about prolapse, I'd be happy to talk about that.
I feel like vaginal discharge is a big one. Are there around that area? I mean, there's others on the phone who might. Do you have in terms of discharge, are there specific questions that you want to ensure are covered when we do the next presentation? Okay.
Vaginal discharge is a big topic. Yeah, okay. Well, I will tell you everything I know about vaginal discharge.
And above that, there's something about blue Crisco as a treatment for vaginal dryness.
I have never used blue Crisco, but I will look into it for you and give you my thoughts on it at the next talk. Yeah. It's like, I'll have to look into that one. I've never used it. But I'd be interested to see what the talk is on that. We typically recommend, like, there's a long list, and I can provide some information on that, of different moisturizers that we use. Yeah, I'm going to send you the assessment. Oddly, if you go to the site, they will not give you the assessment form. However, I have a copy of the assessment form, and it states on it quite clearly that anyone is free to use it as long as they print the copyright. So you will not go to jail for using the assessment form. So I'm going to post it to the website for this meeting, for the MSERS website. But if you go to the website for the public assessment thing, you can't download it from there directly.
All right. Hearing no questions, thank you very much. Thanks everybody else as well for tuning in, and we will talk to everybody soon. Have a great day.
Okay, thank you.
Bye.
Bye.